We're moving on. Our next speaker will help us talk and think about addressing the deluge of data that is in front of us during the pandemic. Erich Huang will talk about data and SARS-CoV-2 chipping away at the Tower of Babel. Erich is the Chief Data Officer for Quality at Duke Health and Director of Duke Forge and Duke Crucible, Assistant Dean for Biomedical Informatics, and Assistant Professor of Biostatistics, Bioinformatics, and Surgery. Erich?
Thank you, Michael. Appreciate everyone taking their time. In many ways, what I'm going to talk about is a bit of a riff off of what Erich Huang is doing very specifically. In that, a month ago, I gave this interview to the folks at MIT Technology Review on their podcast, which they call Radio Corona. And we talked about the chaos of COVID-19 testing data in this country. And I think all of you know this is a problem. In fact, the fact that you know, the Atlantic Monthly provides one of the most authoritative sources of testing data across the country is a sad testament. And what we basically have in many ways, when you think about the ways different states report their testing data, whether that's via fax or, you know, some level of interface, that we basically have a Tower of Babel. I mean, some states are conflating or have in the past conflated serological and RT-PCR testing. So it becomes very difficult to have a national picture of what's going on when it comes to COVID testing. And it's a bit of a sad testament that the federal government isn't able to do that, and that a bunch of very busy workers for the Atlantic Monthly have provided resources like this. And obviously there are other resources like Johns Hopkins and other venues that have provided much more authoritative sources of data for people to think about and address the challenges of COVID-19. At the same time, the federal government has done some good things in the background. What became sort of a buried footnote underneath everything that was happening with the pandemic is that as part of the 21st Century Cures Act, like many of you may know, that when you pass a bill, it ends up having to be actually implemented as a final rule. So the Office of the National Coordinator in the Department of Health and Human Services, which manages thinking about EHR interoperability and things like that, they actually announced the final rule for interoperability and information blocking in March, early March. And so that news sort of got subsumed underneath a bunch of things. But what that actually does is at least start giving us a pattern for thinking about how to chip our way out of this Tower of Babel. And basically what the 21st Century Cures Act has embraced is using data standards, and I'll talk about one in a second, to really promote the concept of interoperability. So then we can get EHR data out in a very standardized fashion, because EHRs are usually highly customized per health system, and the data looks different when it comes out of an EHR. Here's a data standard which allows us to sort of have a template so that we can look at across many EHRs one day in the future, because this obviously has not been implemented broadly by the vendors or the health systems who use EHRs. And so the standard that ONC has embraced is an HL7 standard. So it's an open source standard called the Fast Healthcare Interoperability Resources Standard. So it's really a way to represent electronic health record data in a standardized fashion, and also in a fashion that actually makes it easily transmittable between different types of systems, whether they're EHRs, registries, databases, et cetera. And it embraces a lot of the same standards, basically the same standards that the tech industry has embraced for enabling a lot of the applications that we use on our iPhones, for instance, on a daily basis. Now, what that also gives us a way of addressing, because people say, well, okay, so it's an EHR data standard. How does that help us in clinical research? Well, what we find in clinical research is, and you look at a place like Duke right now with COVID-19, is that we've got a ton of studies. They all have a proprietary database with a proprietary data dictionary. And essentially we're building lots of data verticals. So we're still in building silos of information, even though we're often doing work that are cross-cutting. And one thing that FHIR potentially gives us the way to address this is that it gives us a data standard on which we can build our databases against. And there's a company, well, it's a nonprofit actually called Logica Health, which actually provided a FHIR implementation guide so that it actually pre-specifies all the templates that one would need related to COVID-19, whether that's a COVID-19 test report for RT-PCR or COVID-19 serological report, with all the low-ink and other types of data standards wrapped into this. And what that does is you can put that standard out, and then as people build to that standard, they already have a ready-made, easily transmissible form of the data that allows us to really cut across many data silos. So what one would have instead of all these data verticals is you would have a bunch of COVID-19 related studies that are working against, let's say, Logica Health's SARS implementation guide. And so then we have a standardized set of data elements that everyone can understand, that an EHR can ultimately understand. And so that one has the opportunity of basically building a data horizontal instead of a bunch of data verticals. And what that data horizontal can give us are significantly improved data management in ClinOps, in clinical studies. It gives us common case definitions. So we know when we have a PUI, a person under investigation, implemented using the FHIR standard, that we can actually do an apples to apples comparison between different studies and hopefully even different institutions. And what that also means is that we have the ability to do meta-analyses across multiple studies because they're using the standardized, let's say, demographic information. They're using standardized ethnicity or race information instead of trying to interpret what a particular study had done with their particular implementation of that. What that gives you the opportunity to do is then think about the data elements of a study as being very modular, and that we can have standardized modules such as the standardized FHIR-based module for past medical history or type of residence or medications. And a new study just needs to basically choose from that library of data elements. And then what you can do is you provide that, and you can have multiple studies that leverage the same modules of data that allows you to ultimately do some cross-cutting meta study type analyses as well. And finally, what I want to say is that FHIR actually gives us a potentiality to do things in a way that we traditionally have not been able to do in healthcare, and that we draw a distinction between electronic data capture and EDC in a clinical research protocol versus the EHR. And what FHIR does is it enables you to potentially cut across all these kinds of things. And even better, as we use applications like a web app, it seems like there are about 20 symptom tracking applications out there for Android or iOS. Those speak in the same web language that FHIR speaks. So then it becomes very easy to integrate those apps into your EHR or your EDC or ultimately your disease registry. And what that also means is that all of them can talk to each other using a common data transmission standard. So what I lay out as a challenge for us is there are real public health reasons why we want interoperable data. And it's sort of sad that we have not taken that opportunity at a federal level and a national level to embrace a standardized template of things. And Erich Huang showed you practically how that would really be helpful in many settings. And this is an opportunity for us to, especially since COVID-19 is probably going to be something we have to address over the next couple of years, that we have an opportunity as well to really squarely face the issues of interoperability. And it's for the good of our society as well. So I'll stop there. I know we're running behind on time.